Welcome, Erica. Thank you so much for joining us. And I can tell you just came from seeing patients, it sure looks like.
Yes, I did. Saw patients all morning, and so now ready to share some great information with you guys.
Great. Well, tell us a little bit about your job, your practice, and how you even got into this field.
Sure. Yeah. So I'm an occupational therapist. I've been an OT for 18 years, and I'm from Milwaukee, Wisconsin, and I work in downtown Milwaukee in healthcare system Aurora Healthcare. We have a 70,000 employee healthcare system that I work for, so it's a very large system. And the reason I even chose occupational therapy was my desire really to help people live a better life, to be able to actually rehabilitate and take care of themselves, to do the things that they want to be able to do. And when I was in OT school, there was an OT that came to our class and was kind of talking about some specialty areas of OT, which I didn't realize there even was. And she was talking about how she can help people with bowel and bladder issues. And I just really fell in love with the idea of changing people's lives in regards to that, because it's so significantly can impact how we live day to day if those things are not working correctly. And so when I got into the facility I'm at now, it was a Parkinson's rehabilitation center, or specialty center, and it seemed like a good fit for me to really specialize in both of these areas, because people with Parkinson's disease do suffer from challenges with their bowel, bladder, and sexual health. And so I've really brought those two things together to bring that information and spread it out and tell people about how to handle these things. So I'm excited to share that today.
Great. Well, why don't we get going with your slides? And it's always a pleasure to talk with an occupational therapist. I just love how there's the practical is always so present. It's not, this let's study this phenomenon and just to study it. No, it's like, let's take action. What can we do? There's things that can, address the symptoms. So so glad that you joined us, and I'll zip it and let you get going.
No problem. Thank you so much, Andrea, for introducing me. And just to share a little bit more about my practice, I am board certified in biofeedback for pelvic muscle dysfunction. And so that is a specialty certification beyond my licensure as an occupational therapist. And so took a board exam and did a lot of mentoring on biofeedback. I'm going to talk a little bit about what that is today. And then I'm also a pelvic rehabilitation specialist, and that's a separate board exam as well. That's the PRPC after my name. So definitely have taken some extra lengths to get some additional education so I could bring this all together. I am faculty member, besides a treating clinician full-time in the clinic, I'm a faculty member at both LSVT Global, which is a specialty Parkinson's exercise program, LSVT Big. Many of you may have heard of that before. And so I not only utilize that in the clinic to help patients with exercise, I also travel around the United States and do online learning for clinicians to teach them the LSVT Big protocol. And then I'm also a faculty member at Herman & Wallace Pelvic Rehabilitation Institute. And my role there as a faculty member is that I've authored a course for neurologic conditions and pelvic floor rehabilitation. And so it's a 3-day course that I teach with a physical therapist. She focuses on multiple sclerosis, spinal cord injury, and then I focus on Parkinson's disease. So that's just a little more about my educational background to share with you guys today. So let's flip through a few slides, and then I'll be able to take a lot of questions and we can have kind of an open discussion about some things. So I wanted to first share with you kind of the general prevalence of these conditions in people with Parkinson's disease. So this is a slide that just discusses this questionnaire-based study that is out there related to pelvic health conditions in people with Parkinson's. And just to note, even before I talk about this study, is that there really is very limited studies in this area as far as treatment for these conditions that people with Parkinson's experience. So there's some, but it's just very limited. And so when we see a study in this area of practice, it's very exciting to be able to share this information and try to figure out how we can work on these things. So they looked at 115 people with Parkinson's and 391 control individuals, which were age matched to the individuals that had Parkinson's disease. And so they were both men and women, ages 30 to 69, and all had Parkinson's around 6 years, and we're around Hoehn-Yahr stage 3, which is about middle stage Parkinson's disease, when you have more balance problems that start to come into play. And everyone that was in this study was taking dopamine replacement like carbidopa, levodopa, or some of the other medications you can take for Parkinson's. And so when they looked at women and these kind of symptoms for bladder, the most common symptoms were urinary urgency, so kind of that gotta go sensation, nighttime frequency, so going a lot at night, more than 0 to 1 time in the middle of the night, and then a weak stream, kind of getting the bladder to really empty with a strong stream. So those 3 were the most common. And when you look at those in comparison to the individuals that did not have Parkinson's, which is the second column, the percentages are fairly significantly lower, really in all areas of bladder function in women. When you look at incontinence, definitely stress incontinence, which is the when you cough, laugh, or sneeze kind of incontinence, that's in the 4th line there. That is actually very common even in the general population. And so you can see there's a little more equality there as far as people with Parkinson's and people without. Then when we look at bowel symptoms and sexual symptoms in women, constipation is actually one of the main problems for the bowel that people with Parkinson's experience. And so look at the significant difference between the age-matched control group, 8% compared to 63% of people with Parkinson's experiencing constipation. And difficulty even getting stool out is also another very common complaint. Stool incontinence is actually not as high of a complaint, but definitely still occurs and something that I can help with in the clinic. And then sexual health in women, as you can see, less libido and decrease in the frequency of sexual intercourse. And what we'll notice on this one, I'm going to compare this now to men on the next few slides, but you see the last line, sexual dissatisfaction. Women didn't rate themselves as concerned with their sexual health as men do. They rate the sexual health dissatisfaction a little higher, which we'll see in the next few slides here. So just going back to the bladder first for men, you can see the urinary urgency, nighttime frequency, and weak stream. There's the similarities in men and women experience pretty much the same symptoms of challenge. Men have prostate, which challenges the stream a little bit more than in women who don't have a prostate. And so we can talk more about that as well. I have some pictures coming up that shows how that affects the urine stream in men. And then looking at men with bowel, with Parkinson's versus the control group, again, the constipation really high, as well as difficulty getting stool out, also very high in people with Parkinson's. And then we can see in men with sexual health conditions down on the bottom, there is a lot, it's high frequency difficulty in all of those areas: libido, frequency of intercourse, difficulty with erection, ejaculation, and then their sexual dissatisfaction much higher than in females with Parkinson's. So let's talk about the pelvic floor. So since in therapy we address muscles, this is the one area that we can focus some of our attention on and actually rehabilitate this muscle to do what we want it to do to help some of those conditions. And so the pelvic floor is basically a sling of muscles that connects from the front of the pelvis to the back, and it attaches really on the whole lower pelvis, kind of forming like a bowl or a sling at the base of the pelvis. And so the 4 functions are sphincteric, meaning we can control urination and bowel, and gas, so it kind of tightens around the openings in the pelvis to hold everything in, or let out, depending on if we're going to the bathroom or not. The second thing is that it provides that shelf really for all the organs in the pelvis. So the bladder, the uterus, the prostated men, the rectum, and the colon. The third function is a sexual function, so engorgement of those tissues and having orgasm. And then stabilization, so it works with our core. So in order to keep our balance, the pelvic floor actually also has to contribute to stabilization. So here is what the pelvic floor looks like in a female. So the black in the middle of the picture is the pelvic floor muscle. And we have then the bladder above that in the front. So to the left of your screen, the bladder. And then in the middle, the uterus. And in the back is the colon rectum. And so you can see how all the tubes flow right through that muscle. And that muscle has that bowl shape to kind of hold everything up and support everything. And that's the female. And then the male, we have the black is the pelvic floor muscle. And you can kind of see, so the bladder is on the left side, kind of middle, and the prostate just below the bladder. And so you see how the pelvic floor spans from front to back again and is below the prostate in men, and that surrounds the anal rectum as well. Now, when we think about the pelvic floor, this is a female side kind of view. We're going to look at the male as well, but you can see on the top, the pelvic floor is in like a relaxed position. So that sling of muscle is in the support position, holding everything up. And the bottom is showing that when we contract the pelvic floor, it kind of pinches or squeezes close the tubes that go through there, and it kind of lifts up a little bit. So you get closure and lift to support the area of the pelvis. And you can see on that bottom picture how there's like a shadow of where the pelvic floor was, and then it moves up to just tighten and support everything. And then when we look at the male, same thing. So the top is the pelvic floor and the male at rest. And then on the bottom is when there's a contraction. So you get that tightening closure, and then the lift or pinching and squeezing together to tighten the pelvic floor muscle around that area for control. And so let's look at the bladder, the bowel, and some sexual dysfunction kind of issues that can pop up. So when we look at the bladder, this is another just closer view of the bladder coming through the pelvic floor muscle there, okay? And so what happens is, for example, in incontinence, when we have increase in abdominal pressure, so there's a little pressure on the bladder, like with a cough or a sneeze, or you go to lift something, there's a little pressure that goes onto the full bladder, and if the pelvic floor is not strong enough, you actually can get leakage through the pelvic floor, and then we have incontinence. So that's one type of incontinence. The other type that's actually a lot more common in people with Parkinson's is called urge incontinence. So you get a really strong urge to go to the bathroom, and then urine comes out without you being in the bathroom or by the toilet. And so we can kind of talk about some strategies with the pelvic floor and pelvic floor training to try to eliminate some of those issues. And then the bowel system, so looking at someone from the front, this is the large intestine. And so it goes from, if we think about the bottom left-hand side of the screen, that's where the small intestine empties out into the large intestine. It moves up what's called the ascending colon in blue. Then the stool moves through the transverse colon in green, and then down the descending colon, which is in yellow, and then to the sigmoid colon and out the rectum and anus. So that's kind of the path that it travels. And so in Parkinson's, very common to actually have a lot of fullness in the large intestine because the colon is moving very slow. All of this area is slower. When there's less dopamine in the system, the colon just isn't getting as much signal. And so everything moves a lot slower through, and we get some constipation symptoms. And in pelvic floor rehab, we can actually help with a lot of those symptoms. This is a stool chart that I use when I talk to people about their bowel habits, and we kind of discuss how they're doing. And type 4 is kind of the area we shoot for. We don't want it too dry, which is the lower number, so all the way up to type 1, but we also don't want it too soft. So we want to try to shoot for right in the middle. It helps move it through the colon a little bit easier and helps it come out a little bit easier. And so I also not only train the pelvic floor, but work on kind of behavioral or lifestyle kind of changes that we can make to really make that work better and get things moving on a day-to-day basis. And then this is a chart about sexual kind of things that happen with aging. So looking at men versus women. Now, because Parkinson's disease tends to, not always, obviously there's young onset Parkinson's, younger, or 60 and up tends to be more the common time to get Parkinson's. But as we age, we also are experiencing some changes in the general population. So kind of thinking about Parkinson's versus aging sometimes is hard for a lot of reasons in regards to rehab and Parkinson's, right? Thinking about balance changes and posture changes that happen in general aging population as well. But if we kind of think about the sexual changes that do happen with aging in men and women, our hormone levels change. And so I have that at the top row there. So testosterone levels start to reduce approximately 1% after the age of 30 per year. And estrogen starts to decline by 50% and further decline after menopause. I'm thinking about aging in women. And then generally arousal is less. There's longer periods of time where you can't also then engage in sexual activity because the body takes longer to kind of recover or recoup, or atrophy, which is like a thinning of the muscles or thinning of the pelvic area organs required for sexual activity. Also takes longer to reach full erection in men, sometimes even difficulty achieving more lubrication or ability to have comfortable penetration in women because there's the thinning of the walls of the vagina for women as we age. And then also for men, there's some difficulty sometimes during ejaculation, there's less fluid, or if you don't have prostate, there's no fluid at all. So it just kind of changes the dynamics. So I wanted to just show this general slide. This is my last slide, and then I'm going to open it up to questions. But just to kind of think about how does a decrease in dopamine, so having Parkinson's reduces the amount of dopamine being produced, how does that really affect all these symptoms in general? So I just kind of wanted to give us a general list to look at so that we had something to refer to. But the first thing that I want to just mention back to, and we'll start with the bladder. So when there's less dopamine, what happens is the brain actually is not able to inhibit a bladder signal as easy as it could before. So when we have the right amount of dopamine, what happens is our bladder fills up and we're able to kind of defer the urge when we don't have a super full bladder. We kind of can pass it up a little bit here and there while we're getting other things done. And we can then move on and still get things done. And then eventually the urge does become strong enough where we have to go. In Parkinson's, what happens is when we don't have that enough dopamine to inhibit the bladder, we get very small volumes in the bladder that give very strong urges. So the sensation of the urge will be really strong in comparison to the volume that actually comes out when you go to the bathroom. And so that's something we can work on in pelvic rehab in regards to actually using our muscles, the pelvic floor muscle, to help defer the urge since the brain isn't doing it as well as it did before. And so strength of the pelvic floor can be a very significant impact on that. The second thing I want to mention about the bladder, number 2 there, nocturia. So getting up more than one time a night, 0 to 1 is like the average. So if you get up more than one time a night to go to the bathroom, that can really impact function the next day. And so sleep is so important for function in people with Parkinson's and general as well, but especially people with Parkinson's that already have some difficulty moving and things like that. So the reason I have orthostatic hypotension in parentheses there is that is one of the biggest impacts on nighttime frequency, getting up at night. And so if you've heard of that before, if you haven't, I'll just briefly define that as that orthostatic hypotension is for blood pressure problem that occurs in Parkinson's commonly. Not everyone has it, but what happens is when you go from sitting then to standing, the blood pressure drops significantly, okay? And so there's a certain point scale they use to determine whether you would be diagnosed with that. And so in people that have that, they tend to actually have more problems with the nocturia. And the reason that is that during the day, your body tries to keep fluids in to keep your blood volumes higher, so your blood pressure stays higher, okay? So it's a way of our body trying to achieve homeostasis. So then when you lay down at night, when we're lying down in general, our blood pressure actually goes up a little bit more. When we're upright, our blood pressure is lower. When we're lying down, it's higher. So now the body's like, oh, we have too much fluid. And so a lot of fluid gets released at night. And so your bladder fills up more at night to release that. And then this cycle goes on day after day. So that can be something that can significantly impact the nighttime. And then there are some things we can try in the clinic to adjust for that. But again, blood pressure maintenance is obviously very important. Number 3 on my list there, so slow transit constipation. So because like I mentioned before, the stool can kind of build up in that large intestine or colon. similar term that we use for that same picture that I had up there, in that things just move a lot slower. They just don't travel through as fast. And when they test the speed of stool moving through the colon, they do find that people with Parkinson's do have a much slower transit time to get to the exit. And so that can be of impact in regards to just staying cleaned out every day. Now, the big thing about that is that can actually negatively impact the bladder. So we only have so much real estate in the pelvis, okay? When we have a full colon or full rectum, the bladder has less space to fill and can potentially impact incontinence or urgency to use the bathroom and the nighttime nocturia as well. Number 4, ineffective abdominal strength. So when we have a bowel movement, the abdominal muscles actually do play a role in trying to get stool to come out. And so when we think about other muscles in the body for movement in Parkinson's, how they can give us trouble, arms, legs, fine motor, gross motor movements, the abdomen also is under voluntary control and doesn't work as efficiently in someone with Parkinson's to get stool out. And so in pelvic rehab, we work on actually training the abdominals and the breathing to work better to get stool moving. Number 5 is that the rectum, so this is the storage area for the stool once it gets to the near the exit, just like the bladder, it actually just stores it until we give permission for it to come out when we're on the toilet. And so there's actually a reduced rectal contraction ability with less dopamine. And so using number 4, where we train abdominals to help, that can actually also help the rectum empty. Number 6 is something that some of you may or may not have ever heard of before, but paradoxical contraction of the pelvic floor. So what happens in people with Parkinson's, movement can become incoordinated. And so the pelvic floor can have the same problem since it's a muscle. And so the pelvic floor actually might close instead of open when you're trying to go to the bathroom. So you get sphincter closure, and now the stool can't come out because the exit is closed. And so in pelvic rehab, we work on training that coordination as well. Number 7, when we have less dopamine, because it drives passion and desire and motivation, we can have reduced libido for sexual activity. So general kind of like a dampening of our desire to have sexual activity. And occasionally, just on the opposite side of that, dopamine replacement medications, dopamine agonists in particular, sometimes and have been noted in the literature to cause some hypersexuality. So that actually can be something that's medication induced as well. And then number 8, slowness in our other muscles of the body can also affect the pelvic floor. So bradykinesia, which is that slowness of movement, can also cause a reduced reactivity of the pelvic floor. So we can have delayed reaction to an urge, and then we have incontinence. So we can't get the muscle to squeeze fast enough, like the muscle maybe gets frozen a little, and we can't activate it fast enough to stop the bladder, or it's too slow to let go when you try to have a bowel movement. So for example, the bowel urge comes, you get in there, and now you can't go. And so maybe there's that delay in even just relaxing the pelvic floor to tell the bowels to empty out. So that can be a challenge in both of those scenarios. Okay, so that's kind of a quick summary. I wanted to give us some talking points. And then I have my contact information within the PowerPoint as well, so that you guys can let me know if there's anything that you may need in the future too from here. All right.
Okay, great. Thank you. So I'm going to switch from screen share mode to face mode. And if we do need to refer back to any of your diagrams, feel free, Erica, to just pop that back on the screen share, if we need to look at the, one of the anatomy pictures. So,
Sure.
So now we want to hear from all of you. So my colleague Becky there, hi Becky, is going to be monitoring and look for, people waving and indicating that they want to ask a question. We now have turned on the switch where you can unmute yourself and ask a question. But I have a starter question while everyone kind of lets things sink in and formulates a question in their head. So this is from Douglas Bailey, and I had the same question, Douglas. So What, Erica, are some of the exercises that, you have someone, okay, they've identified the problem, talked to their doctor, gotten a referral to you. What are you actually doing? What are the exercises?
Sure, absolutely. So Douglas, yes, very good question. So what we want to think about is the fact that this muscle, pelvic floor, does two different kinds of contractions, okay? So we have a quick reaction fiber, like our power contraction, and then we also need endurance in this muscle. Okay, so we have two different fibers. They work together. They're all kind of weeded together within the pelvic floor, and we need to exercise them both. So the first kind of test that I have people go through with me is first, let's even find the muscle. Like, how can we even find this muscle, make sure we're using the right one? And we want to be able to use it in pretty much isolation from every other muscle. It should be a private contraction. So like, for example, if you were in a space where there was other people around and you wanted to hold back gas, okay, we can tighten in the back area, like in the anal area, and feel a tightening there. And that's kind of how I help people to become aware of that, because obviously that's something that most people are at least familiar with. They're trying to hold back gas when there's other people around. Sense where the muscle is in the back, and then we can also try to feel how that actually contracts also in the front. Same muscle that controls the back area controls the front. The sling of muscle is that full span from your pubic bone to your tailbone, basically, and we can kind of sense that close and lift. So now thinking about what I mentioned about power versus endurance. So what we do is want to train a quick contraction, about 1 to 2 seconds, okay? So where you pull and release. Pull and release, okay? So it's a very quick tightening for power, maximal, and then release, okay? Then when building endurance, we work on maybe a 5, 10 second, 20 second, depending on the person, work on a longer duration holding. So you close, lift, kind of tighten that pelvic floor. We hold that for a duration that we select depending on your problem. And then we work on relaxing that for approximately usually the same duration. So if I choose a 10-second hold, I typically choose a 10-second relaxation. And so I see someone asking, are these Kegel exercises? So Kegel is the gentleman who actually created these way back in the 50s or 60s. So that's his last name. And so yes, these are basically Kegel exercises. They're generically called pelvic floor exercises. But yes, that is exactly what you're thinking, exactly correctly. So the key to training this muscle is that we use it in pretty much isolation from all other muscles, not using your legs, not using your abdomen, not holding your breath. Because all of those things impact the control of the bladder and the bowel. And so I work with those exercises, and the way that I assess them is either digitally, so we get trained as pelvic rehabilitation specialists to use our hand for manual pelvic assessments, as well as biofeedback. So I mentioned that I'm trained in that before. Uses a sensor, either for, in females, a vaginal sensor or an anal rectal sensor. It's about the size of a tampon approximately, if we want to kind of think size-wise. And we can insert that internally. And then on a computer screen, I can actually see on a graph, what is that muscle doing? I can actually watch it contract, watch it relax, and train that person's abilities depending on what I see, which is really nice. And it's great visual feedback for not only myself, but the person I'm working with, and a great it works to measure session to session as well, improvements, which is really, really a nice thing. So hopefully I covered that question.
Yeah, very good. Let's see. Okay, we're gonna turn right a little bit and talk about some bowel movement questions. Okay, so there's two. I'll start with the first one. And I think you can see these two, Erica, but
Yes.
I think the question has to do with physiologically, could you speak to, a bowel movement emergency, no warning, I don't know if urgency is the right word, and maybe even fecal incontinence, like what
Sure.
in the body is happening there?
Yeah, absolutely. So I would say, like I mentioned earlier, fecal incontinence is actually a little bit less common in Parkinson's only because constipation tends to be a main thing. However, The issue that can happen with fecal incontinence can be kind of two different things. We could have well, it could maybe even be three things. So if the stool is too loose, that's something we have to be concerned with. So I always am asking a lot of questions, like using that chart and trying to figure out what is the consistency of the stool, and actually how often are you going? Because if you are constipated, you can have looseness in the stool because it sneaks around hard stool. Or if you're not constipated, you can also have loose stool for other reasons, maybe dietary or something else. So in regards to urgency of a fecal event kind of needing to go, this can be due to potentially being constipated for a few days, and all of a sudden the system is like, whoa, we're going to rev up, it's time to go. And so there can be kind of that unexpected thing. Or it can just be because maybe the consistency isn't quite right with the stool, and we have to work on that. Or the other thing is, so the rectum is supposed to be the storage area that we can postpone a stool urgency when we're in like a public situation. And so sometimes the pelvic floor muscle is not reactive enough to encourage the storage. And so what I mean by that is the rectum stretches to a certain level and gives a signal to our brain to tell us that the urge is coming, okay? Now, if our pelvic floor is not strong enough or not efficient enough or isn't working correctly, it won't tighten to the level to kind of put the rectum in storage mode or calm it down. And so then the rectum is kind of still in empty mode, and then we can have leakage, if that makes sense. So training the pelvic floor really can help to actually then control the rectum, which is really involuntary. We don't have control over the rectum unless we use the. And it's the same with the bladder. It's the same exact concept with the bladder.
Yeah, it's interesting. So often, we discuss, diet and nutrition to impact, bowel movements. So it's fascinating to hear actually, from the pelvic floor angle. There was another question, and I'm realizing maybe in general, this topic, people would rather not unmute themselves and ask on camera, and it's a little, it's easier to send through the chat. So whatever you want to do, guys, and also you can send private messages to me too if you don't want, 119 of your closest friends to know your business. So we'll get the information out no matter how you want to ask us. But just a follow-up question relating to diet and loose stools and constipation. How do you, know, how do you factor in the diet variable, or, do you just do what you can with the pelvic floor? Can you kind of talk about how diet and nutrition overlap?
Sure. So the diet piece is very challenging, no doubt, because everyone's body is so significantly different in how we react to food intake and such. And Parkinson's just complicates that even a little bit more, because not only are we getting slowness in the large intestine or the colon, but the stomach empties at a slower rate as well. And then that affects the medication activation. Once the medication comes out of the stomach and goes into the small intestine, that's where the dopamine is absorbed and utilized by our brain. So it's very, very complex. Now, the typical recommendation for, say, fiber, if we even just start there, fiber and water. So fiber is recommended to have 25 to 35 grams of fiber a day. Approximately. Now, if you're one that doesn't typically eat a lot of fiber and you go from 6 grams a day to 25 or 35 in one day, you won't be too happy with me because it will stop you up. And actually in Parkinson's, a lot of fiber can slow things down. So because of the slowness already in the system. So it is really a challenge actually, and a lot of manipulation that we kind of can work together through. And I'm not a dietitian. However, I do work with dietitians. So I have some basic knowledge that I apply when I look at, say, a diary. Maybe we'll take a food diary and look at it together and look at the frequency of the bowel movements and what the types of bowel movements that person is having. And then we can kind of analyze that together. So the other piece of the fiber is that if you're not taking in water, the fiber does not activate and actually stops you up more. So water recommendations currently right now is half your body weight in ounces per day. So that's very important. If you up your fiber and do not up the water, that's another really, really challenging thing for the body. We need that water to activate it, that fiber. So that's really kind of a balancing act that we have to figure out together. But really, you know, in general, thinking about balanced meals and eating right. I mean, all the things that you probably heard about Parkinson's and diet. If we really stick with healthy diet, food groups, and all of that, that can be really helpful. But water is very important. The other thing that can kind of facilitate bowel activity when we're kind of upping the fiber in the water is exercise, moving around and staying active. Very important for the bowels.
Okay. Question now, kind of related to exercise. Are there things that predispose people to a weaker pelvic floor? Is, you know, having a desk job and sitting down all day, does that, you know, predispose people? Things like cycling, which is done in a seated position and, you know, has pressure on the pelvic floor, does that affect or make things worse?
Mm-hmm. So there's a lot of stuff in the literature about, you know, what really makes the pelvic floor, say, weaker in one person than another. And actually the main thing is genetics. So what you've inherited from your ancestors along the way down can actually change how your tissues are responsive to the everyday challenges of life. So that's probably top of the list. Now, women that have had babies vaginally, even C-section. There's a lot of kind of conflicting information about, you know, what really makes the pelvic floor weaker. But it does seem that women that have had babies and things like that do tend to have more laxity in the pelvic floor, so may take a little bit more to strengthen it and or work on it in that way. So other things, chronic coughing also overstretches the pelvic floor. Chronic lifting, heavy lifting jobs also tends to cause some damage potentially, depending on how you've lifted all your life and how, you know, your body mechanics are. So those are also very, very common reasons why the pelvic floor might not be as effective. Now, biking or sitting all day at work, those actually might be more related to potentially compressing the nerve that activates our pelvic floor, and that's the pudendal nerve. It has kind of a treacherous path from the spine, from our sacral spine. That's the very low part of our spine, below our lumbar spine. And so that area can sometimes be compressed when we sit. And so that nerve can get a little bit of compression. I would say definitely that's more common in a younger, more active person that does do a lot of sitting or compression in that area. That is not probably high on the list of things that I see in general for someone with Parkinson's, but in relation to maybe other things in their life that affect them environmentally.
Okay, great. Thank you. Let's see. Okay, so there's been some questions about the exercises.
Okay.
So things like, do you give homework and, you know, teach people exercises and then they go home and do them? Are there ways that people can, you know, look online and learn the exercises without going to an OT? Obviously, everyone now wants to drive to Wisconsin and see you because you're so good at explaining things and just have this wealth of knowledge, but not possible for everyone.
Yes, I understand.
Can you speak to that?
Yeah, so I do absolutely give homework. So the big thing with the exercises to think about, if you want to try them on your own, absolutely you should. So the quick contractions I was talking about before, working with the power part of our muscle, holding for 1 to 2 seconds, relaxing for 2 seconds. That's kind of the basic. Now, when I train it, I always make sure that everybody is also relaxing and not just squeezing. So if you work on just squeezing, you think about like your bicep. If you tighten your bicep and you let it go and then you tighten it again, you get pretty good workout in your bicep. But if you never let it go and you keep going like this and tightening and tightening and tightening and tightening, we never actually get good strength in the muscle, okay? So what you wanna make sure when you're doing these exercises is that you have the contraction and you have the relaxation. Both so important for bowel and bladder function, okay? And actually sexual function as well. The reason that is if we get that muscle too tight, then we can't empty as good. So you think about tightening holds things in and encourages storage, loosening encourages the emptying part. So if we're not emptying efficiently, that's a whole different problem as well, okay? And we already have this constipation kind of thing looming and potentially a weaker stream. And so we wanna make sure the muscle is trained in both tighten and relax. Okay, so that's the quick squeeze. So 2 hold, about 2 rest. If you don't feel like it lets go completely, you should rest a little longer.
Get rid of her now.
And so you're gonna do 10 of those approximately about 3 times a day. So usually I recommend those as the initial 3 times a day, 10 repetitions. And then the longer holds, so holding for approximately 10 count, is a good start. And sometimes if you can't feel like you're holding it for a good 10, maybe hold it just for 5 to start and build up. So holding for 10 and then relaxing for the count of 10. So kind of equaling out the hold and the rest and doing those 10 times, 3 times a day. Now with the longer holds, if you try to hold at your maximal level for 10 seconds, that's gonna be really hard to do. And so for example, like if you go to the gym and you can say you can lift 80 pounds, but you can only do it once, you don't wanna just keep trying to lift 80 pounds. You wanna maybe lift 20, 10 repetitions. So that's kind of the idea with the long holds is you're trying to build more endurance. And so you use maybe a sub-maximal training level on those longer holds where you're holding for that duration for those. So I usually, like I mentioned, really starting about 3 times a day for each of those in training. And we try to shoot for maybe 2 to 3 months of work at that level because that's about how long it takes to actually change the muscle. And then we can go on a maintenance schedule of some sort, so.
Okay. Wow. I think it's hard because we can't see that muscle work, and I think understanding what's actually going on can be difficult. So I can really see the value of working with a professional, and even a professional with the gadgets of the biofeedback. There was a question about, speaking of gadgets, so on the internet, there's some new gadgets out there. Someone had a question. There's 2 that have questions. One would be Kegel ball weights, and the other would be, they don't know the name of it, but it's, I think it's mostly for women. You put it in the vagina, and as you squeeze, it shows up on your phone. I don't know what that's called.
Yeah, there's a couple of those actually. So let me start with the weights. So vaginal weights, they're typically called. And so in the literature, they actually show that vaginal weights versus isolated pelvic floor exercise, like I was just talking about, are almost equal. So the times that I introduce those is if I've done everything I can to try to strengthen that muscle first in isolation and we still can't quite get it, then I may recommend something like that for resistance. It really, like I said, the literature kind of shows almost equal. Like if you use them or you don't use them, it's almost the same. There's also something called electrical stim, which we can use in the clinic, and there's also machines that you can use at home that actually gives a little bit of stimulation through the muscle. It's not painful when you use it correctly and you can be trained on it. And it actually helps the muscle contract a little bit and tighten with you. You exercise with it. And so it can exercise and tighten you beyond your own ability. And so a lot of times, I actually use that a lot in men who've had a prostatectomy. So if they've had maybe prostate cancer and they've had their prostate removed and they just can't quite get continence back after, the stim unit actually helps significantly for them. So that's that one. Now biofeedback, those gadgets you can use with your phone, like a Bluetooth, like you insert something and you use a Bluetooth. So the most common ones that I know of are the Elvie, E-L-V-I-E, and the K-Goal, K and the word goal. And so I typically, I mean, I don't really recommend only one type. Those are just two that I'm most familiar with. But yeah, Bluetooth right to your phone, and you can actually sometimes see graphs and goals and different ways to use it on your phone, which is similar to the clinic biofeedback, just a little more game-like per se. And then you can record progress over time. So yeah, those things are absolutely good options for if you can't access someone like myself to try to work on some of these things. The big thing with these biofeedback type things is just remember that you not only just want to work on the tightening, but the letting go too. So most of them do train a lot on the squeeze, 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 but you want to just make sure you also allow the muscle to let go between each squeeze so that you can get efficient strengthening.
Okay. And okay, so Millie's a personal trainer joining us, and she says that in her practice, she gets creative with cues for visualization.
Great.
And then Larry was wondering, so all of those biofeedback gadgets that you mentioned are for women, and the stim, you have to go to the clinic for that. There's not a home version.
There is a home version, but it's better to be trained and see if you'd even like it in the clinic first, and then we can work on getting a home unit from there. Yes.
Okay.
Yeah, I'm not familiar with a one that's specifically made for men. So that's a really good question. I don't know of an internal device for men per se, except a medical grade version of one, a biofeedback, because there is an anorectal internal sensor that I use on men. And so that one hooks up to the medical unit I'm most familiar with for biofeedback. There's one that I use in the clinic, but there's also a handheld home unit for that too. So for men, that would probably be the one that I would recommend. They would just need someone to help facilitate that medically for them.
Okay. And then David wanted to know about good old-fashioned free breathing exercises, deep inhalation followed by slow exhalation.
Yes.
To me, that doesn't say pelvic floor specifically, but is that a technique?
Yeah, so very good. Breathing is excellent. Let's talk about that a little. So the diaphragm and the pelvic floor actually work together. So let's think about the diaphragm and the pelvic floor like you have your diaphragm up here and your pelvic floor here. When you breathe in, your diaphragm comes down, your pelvic floor actually comes down a little bit. So diaphragm down, pelvic floor down. When you inhale, you exhale, diaphragm comes up to push out the air, and the pelvic floor comes up. So that's actually the natural movement of pelvic floor and diaphragm. They move together. So we have like a canister in the trunk of our body, and they work together in that way. And so we can actually use our breathing, like diaphragmatic breathing is one of the generic terms that we can use for breathing. And what you do is make sure that kind of the terms we use to help like get the sequences, like smell the roses, so breathing in through your nose, and blow out the candles, breathing out through your mouth. So when you breathe, what you want to think about is you want to think about your rib cage like an upside down, well, like an umbrella, basically. So when you breathe in and you're getting your diaphragm to drop, you want to think about the rib cage opening like an umbrella. You get the air into the abdomen. And then when we breathe out, the umbrella closes and we get compression back down. Okay, so diaphragmatic breathing and lying down, sitting, that's a great technique. Now, one of the techniques, just to go along with what the person's question maybe was, that I really, really like is called 4-7-8 breathing. I use this actually in training for bowel movements and for relaxation and sleep and things like that. So what you do is the breath of 4 count, is a breath in through the nose for 4, and you follow those techniques of kind of feeling it in the abdomen. The 7 is actually a breath hold. So a gentle breath hold, not a straining or anything like that. The 7 is a holding that breath in. And the 8 is letting that breath out. So using, what's interesting is we can use the 8 breath out in a couple ways. You can use the 8 breath out in a big whoosh to let the air all out quickly. That one's not as effective in my personal experience, but instead using a little resistance with the 8 out. So pursing the lips or saying the letter S. Now, what I want you to think about is if you put your hand on your abdomen, kind of by your belly button, and during that exhale out, when you say with an S, you can feel the abdominals tighten a little bit. Now, what I want you to think about is something I mentioned before, in that abdominal strain is reduced in people with Parkinson's and they have trouble getting stool out. So I use the 4-7-8 breath with the 8 exhale resistance to help teach the correct way to use the abdomen to help evacuate stool. So that kind of combined two things, maybe with the question about breathing and about using that for bowel movements, is extremely effective for that.
I love that. Such a practical tip that you don't need any gadgets or equipment.
Exactly.
And the next question is similar, because I think we learn about how, whether it's guided meditation or yoga, any of these wellness practices that have breath components, it's great to know that those benefits, are sometimes immeasurable, that, they affect many aspects of living.
Yeah, and Andrea, on that note, with other like meditation practices and such, if our systems are wound up and we have any anxieties, or we're kind of in flight or fight mode, is one of the common things that people say, like that actually slows our bowel system significantly. Okay. So the term rest and digest means that we can get the bowels moving better. And so any of the breathing practices, any of the meditation practices, all of that actually encourages the bowels to move better.
Mm-hmm. Love it. You're right. You can't, if you're running from the saber-toothed tiger, that will shut down. Yeah. So the next question is kind of similar. Does exercise in general, does overall muscle tone, as improvement as a result of exercise and strength training, also does the pelvic floor maybe get lumped into the benefits, even if you're just doing general exercise? And then someone wondered, are there specific moves? They've heard that kettlebell swings and squats are good for the pelvic floor.
Okay, good. So yes, general exercise will tone all of our muscles. So that is definitely very good. What I always encourage though is pay attention to what's happening to the pelvic floor during exercise. Like we just don't normally pay attention down there. So sometimes people hold really too tight down there, like everything is so tight down there. And sometimes it's just too lax. We're not paying any attention to it. So if you actually just have a little more awareness of what's happening there, you can enhance your ability to use the pelvic floor during your general exercise. So that's really good. Using some of the progressions that I use for pelvic floor exercise beyond what we talked about in isolation are some of those things, like the kettlebell swings works on a lot of core support, and pelvic floor is part of your core. And so you will have activation of your pelvic floor. You can actually, again, consciously be aware of the pelvic floor and be tightening it during some of those exercises. Squatting, another time that tends to be a time when you challenge the bladder a little bit in a squat. Say you're going to lift up a laundry basket, or you're going to lift something in the yard or pick weeds or garden, and you're squatting. That tends to be a time where the pelvic floor is a little more vulnerable to bladder leakage, because you're kind of stretching the pelvic floor a little bit. And so by working on squats with your exercise program and tightening the pelvic floor during the squat, you can actually work on activating the pelvic floor during squatting to help with things you enjoy doing that might potentially cause leakage for you. And just have support in general, like women that have had babies or even haven't, depending on their hereditary or genetic kind of components of their pelvic floor, may have something called a prolapse, where the bladder or the uterus or even the rectum kind of falls or sags down into that area. And the pelvic floor needs to be a good control point or support point for those organs. So I do work with a lot of people that have those diagnoses as well.
Okay. Oh, and sorry, Dorothy, I missed this question earlier, but is sitting on the toilet for an extended period of time damaging to the pelvic floor?
Very good question. It can be. If you are straining with breath holding, that is the worst thing to do for long, long periods of time. So that's why I talked about the breathing before. So position on the toilet can really help with that though. So if you have a stool under your feet, so that you're more kind of almost in a squatting position, leaning forward on your knees with your arms, okay? Kind of the squatty potty is the most popular kind of thing that we maybe would refer to right now, Bed Bath & Beyond or Amazon or wherever, but getting that squatty potty underneath your feet or a stool of any sort and leaning forward helps to put the pelvic really the pelvic tissues, the pelvic organs, and the pelvic floor in the best position for evacuation of stool. And so being in that position and then not holding your breath to strain, because that can damage the pelvic floor in that it's over. What happens is, remember I mentioned the word paradoxical contraction of the pelvic floor. So what happens is when you strain and breath hold and close your throat and go and kind of hold right here, the closure of the upper kind of portion of our airway also closes our pelvic floor or our sphincter. And so if you're sitting there and going like that, you actually are pushing against a closed exit. And so the air and pressure has to go somewhere, and it can overstretch your pelvic floor because it has to push somewhere. So it's pushing on the colon and it's pushing on the pelvic floor, and you can get some overstretching. So I usually recommend 10 to 15 minutes on the toilet at a time. Best time to sit is 15 to 30 minutes after you've eaten something.
Got it. Okay. Let's see. I'm going to scroll through and make sure I didn't miss any questions, but
I did see one pop up about erection and pelvic floor muscle, just briefly. They don't always stay on my screen, so I apologize if I've missed some. But erection, sexual health, pelvic floor. So the pelvic floor muscle being stronger does actually help with erection for men and actually for women as well. So if we have weakness in our pelvic floor, the blood flow actually doesn't stay in the area as well. Okay, so for men, support of the pelvic floor actually helps more blood flow stay in the penis for an erection. And for women, blood flow is important for lubrication. So we sometimes think that the vaginal area is actually lubricated by glands, but it's really primarily actually blood flow that helps lubricate the area. And so for both men and women, it can help with that kind of preparing to have sexual relations with their partner in regards to getting more blood flow to the area. Keeping the blood flow there actually enhances ability to perform in those ways more comfortably, and having even more just preparation for having penetrative intercourse can be really more comfortable too, because women, as we get older and experience menopause, have thinning of those tissues too, and so it can be very much more comfortable when there's lubrication and good blood flow. So
the pelvic floor, just I can see why you're passionate, and why you are drawn to this. I mean, it just intersects so much of our life.
It does, yes.
Okay, well, we are.
Looks like Arthur is raising his hand.
Yeah.
No, I had a question I sent on chat, but what about Miralax? Do you suggest that?
Yes. So Arthur, thank you for the question. So Miralax is one of the most commonly used laxatives in people with Parkinson's. Physicians recommend that very commonly. The one thing that I tend to see is that people will take it and then not take it, and then take it and not take it, depending on how they're feeling. And really the more consistent use of it is actually better. However, taking a full capful every day can sometimes be too aggressive. And so a lot of times I work with the person on seeing what is that just right spot as far as how much can we tolerate in the system, like say even only a tablespoon a day or something like that. And then figuring out, of course, what time of day works too is always some challenge, but taking it in the morning is pretty common. But finding that just right dose and being consistent every day keeps things cleaned out regularly. Okay.
Thank you. Thanks for chiming in, Arthur. Oh, we got the double thumbs up. All right. Well, we covered so much in this hour. It has flown by. This recording should be up on YouTube as soon as their servers allow us. Usually it's within 24 hours. And if you would like a copy of the slides, Becky will put the process in the chat. Basically, you just email us your request, and then Erica has said that it's okay for us to share it with you. So Thank you again, Erica, for joining us. You are obviously so knowledgeable and well-rounded, and I think you gave us a lot to think about, some conversations to have with our care team, even some, practical tips, everything from, that the 4-7-8 breathing technique, some maybe pelvic floor exercises for us to try if we can't see an OT in clinic. But any closing words, not to put you on the spot for a inspirational bow on it?
Yeah, what I want people to know is definitely tell your doctor about these challenges, because there's a lot of people out there like me who know a lot of this information, and I'm trying to share it widely as well in my faculty role. Herman and Wallace Pelvic Rehabilitation Institute is the company that I work for, and they have a clinician directory there where you can seek out clinicians that are certified in your area. And so I just don't want you to be afraid to mention it to the doctor. Let's try to get the help that you can get from these individuals. And I think a lot of times the neurologist appointment is focused more on the motor symptoms and not so much these other things. And definitely don't be afraid to ask, because there is help.
Thank you.
Thank you.
And I did find that link. I'll add that to the chat and we'll include it with the recording. But thank you for joining us. Thank you everyone for your great questions and your attention. And we always say thank you to our speakers with a goodbye wave full of love and gratitude. So,
thank you so much.
if you put it on gallery view, you can scroll through and see all the smiling faces of people just so appreciative for you sharing your time with us. So
yes, thank you so much. Okay.
Thank you, Erica.
Have a great day, everyone. Bye now.
Bye.